Thank you very much for the very kind words and introduction. As you can probably tell, I'm actually local to this part of the world, so it's good to be back. So yes, I'm David Lilburn. I'm a relatively new senior lecturer and consultant in PET imaging at the KCL GSCT PET Centre. So I'm here today to cover novel theragnostic imaging agents in brain tumours, which hopefully will follow on from the two previous talks. So I don't have any disclosures to make with this presentation or work. So the outline is pretty much going through the background of theragnostics in brain tumours, and then moving on to the current theranostic agents, then talking about some of the research agents, which I hope will answer some of Professor Chalmers' questions and challenges as well. But I will predominantly focus on gliomas, but then I'll talk a little bit about extra-axial tumours and metastases. So I'm sure I probably don't have to educate this audience too much about theragnostics. Bearing in mind we are at a nuclear medicine conference, but the sort of principle is pretty much that you've got the integration of a diagnostic biomarker for assessment of the tumour with a closely linked targeted therapy. Often these are the same ligands for diagnosis and treatment, but they aren't always the case, such as with technetium bone scans and radium chloride for osseous metastases and prostate cancer. Now, it is one of the first examples of true personalised medicine. We were trying to give the right drug to the right patient at the right time, which I think is very apt in terms of brain tumours, because as Dr. Hughes was just mentioning there, tumour heterogeneity is a real big problem with brain tumours, and historically we never really accounted for inter-patient heterogeneity. We tended to assume, that a person had a GBM. It was the same as another patient's one. That's obviously changed now, but also you also got quite significant intratumoral heterogeneity as well, because not all parts of the same tumour are the same. And then, particularly when we're talking about metastases, the brain metastasis might have picked up several new genomic mutations compared to the actual primary as well, so it might be a slightly different phenotype from the primary tumour. And then, particularly in the era that we're in just now, where patients are tending to live longer with metastatic cancer, and they're going through several lines of treatment, there is a temporal evolution in the tumours as well. I guess for primary brain tumours, these are very, very infiltrative. So potentially molecular imaging will be able to map the tumour spread more effectively, particularly if it's used in combination with MRI or CT. So overall, the sort of aim, as we all know, is to increase the targeting of the cancer cells and to hopefully reduce the toxicity to the surrounding healthy tissue or elsewhere in the body. But to do this, it requires the identification of a target which has a sufficient level of expression before therapy can commence. So just a quick overview of the biological effects of molecular radiotherapy. We tend to talk about the direct effects and the indirect effects. Here you've got your theranostic agent, which has a alpha or beta emitting radionuclide attached to the ligand. You've got the direct effects on the DNA damage, but the majority of the effects actually occur because of the generation of free radicals from the ionizing of water, which then causes breakdown of proteins, RNA, causes lipid damage, and particularly to the cell membranes as well, which eventually, hopefully, results in cell death or apoptosis. Now, there's obviously been a revolution in this field in the last 20 years. Historically, we only had really a few radionuclides that we could use, which were predominantly beta emitters, which had a longer path length, which had some benefits because obviously of the tumour heterogeneity and so on. You would then get better crossfire effects to the tumour itself, but now we've got alpha emitters and also Auger electron emitters as well, which have got much shorter path lengths, so you can actually confine the radiation dose quite closely to the site of uptake. In terms of the biological effects, it isn't just the effects of the radiation itself, it's also the effects that happen as a result to the tissue. So here we've got in orange, we've got the swollen, the swollen cells which have had the highest dose of radiotherapy, be it external beam or MRT, and then around that you've then got this penumbra of cells which have had lower amounts of radiation and cells even further away which haven't had very much radiation at all. So what this does set up because of apoptosis, intercellular signaling is an immune response with recruitment of antigen-presenting cells, T cells and so on, and then you activate the immune system. We've got the local radiation effects, which are predominantly classed as either the cohort effect, which is just the direct signaling between cells which have had slightly less radiation and those which have had a higher dose, and then you've got this bystander effect, which is where, due to the local inflammatory mediators, etc., you then set up various pathways there which result in further cell death of even untreated cells. And then, quite surprisingly to me until I read into this, you've also got the distant effects as well due to the recruitment of the immune system. So I guess the question is, why have we had so little success in brain tumours so far? I mean, I think it's quite telling the fact that in 20 years, the average time from diagnosis to death after the diagnosis of a GBM is under 18 months. The average survival, I had to double check this, after being diagnosed with a brain metastasis is 6 months, although that has changed now for quite a few of the cancers. But the key problem is the blood-brain barrier, which is selectively permeable and provides an immune and chemically privileged environment for the brain, but also for the brain tumours as well. And what we often see is that that the blood-brain barrier, the BBB, is intact for the lower grade tumours, but it progressively breaks down with the higher grade. But it isn't homogeneous across the entirety of the tumour, which, as I've already spoken about, is one of the problems. And here, you've just got an illustration of what happens with the blood-brain barrier. Your astrocyte foot processes detach, your basement membrane becomes disorganized and leaky, the tight junctions between the endothelial cells break down as well. I guess the other thing to comment on is that the higher grade tumours tend to be quite cystic and have hypoxic components, which can make drug delivery more heterogeneous also, although hopefully MRT should alleviate some of this. So, what is the ideal molecular target? I've just listed them here. We can all read, but anyway, the target should be expressed homogeneously throughout the tumour tissue. It should be exclusively expressed on the tumour cells in the TME. It should be accessible from the systemic circulation so that we can hopefully give repeated doses of the radiopharmaceutical, and it should be consistently expressed over time. But the catch is no such target exists, okay, at present. So we also have to think about from the oncologist point of view. I mean, how are we going to deliver these therapies? Now, intravenous is the easiest to do. Patients can be outpatients and can come in for repeated administrations. But the trouble is, though, is that it often is limited due to the dose that we will give across the whole body and to the healthy tissues. And particularly if we still have an intact blood-brain barrier, this can be a problem. And then we also have to deal with metabolism and excretion within the body. Intra-arterial delivery methods have also been used, which are potentially better because we can feed it into the actual artery, which feeds the tumour directly, but it still has the same issues with the blood-brain barrier, penetration and heterogeneous uptake, and plus it's a more technically challenging procedure where things can go wrong. We've also got intrathecal, which avoids the blood-brain barrier, but it's limited in terms of where the tumours are located. And here you also have quite a lot of toxicity to uninvolved healthy tissue and complications. There has been quite a lot of work with intratumoral, both in terms of the sort of what we think about, sort of injecting the radiopharmaceutical directly into the cavity, but also with what are also called convection-enhanced delivery methods, where there are a series of micro catheters which actively pump the radiopharmaceutical into the tumour itself. And this is probably the best, but it is the most technically challenging. It's limited to uber specialist centres, and you have got a small risk of tumour seeding as well. There have been a lot of thoughts about, particularly for the intravenous delivery, how we can improve this. The issues, these are generally, the radiopharmaceuticals are generally complex molecules, quite heavy, not always lipophilic, perhaps don't have very good transport mechanisms across the blood-brain barrier. So there's been a whole host of fantastic science and work taking place in this field, which, to be honest, I could have a whole talk on that, really, although I'm probably not the best person to do it. But I think what is quite exciting now, though, is that these things now are beginning to make their way through to the clinic, which is great, particularly in terms of osmotic diuretics to break down the blood-brain barrier, and then some of the mechanical techniques as well. So, getting on to what are the targets then, there's a plethora. There's been a whole host of work and invention in this field. Quite a lot of it's been preclinical, but it is beginning to get translated into the clinical domain. You can see here, you've got some targets for the extracellular matrix, such as FAPI on cancer-associated fibroblasts, some glycoproteins, also angiogenesis, and then cellular markers on both on glioma cells, meningiomas, and brain metastases as well. So I'll just run through a few of them. I obviously won't have time to go through everything, and I think I'd probably send everyone to sleep if I did. So the first one that was used was tennyson C, which seemed like a very good target because it was expressed by multiple cancer types and only in the fetus during organogenesis. There was some work with some iodine 131 labelled murine monoclonal antibodies, and they had, it was small case numbers, I think under 10 patients, but 40% response rates. There were some follow-up trials in the 2000s and so on as well, using both iodine 131 and astatine 211 radioisotopes, which had promising results, but suddenly it stopped in 2006, and we've not heard anything else about it, which I think is a real shame because it does meet quite a lot of the criteria that I alluded to earlier. So next we're going on to angiogenesis markers, which are considered a hallmark of tumour aggressiveness, largely due to the disrupted blood-brain barrier. There's been quite a lot with integrin tracers. You can see here a case where you've got patients who are pre and then post radiotherapy with adjuvant temozolomide, and you can see that in the patients who don't respond, that there's quite clear progression in uptake, whereas those patients that do respond, it's probably slightly better, but it definitely hasn't gotten any worse. EGFR, which I know isn't just angiogenesis, but it tends to have its main action via VEGFR or VEGF, and there has been quite a lot of work taking place in this field, but it hasn't got above trials of 10, 20 patients, which is a problem. Yeah, no problem. PSMA is another one which has been getting used quite a lot, though, because it is also expressed in the neovasculature of GBMs, but I'm not quite so convinced by the sort of uptake levels that you see, and you've got a lot of off-target uptake, which I personally have some issues with, but you can see, though, that it is potentially a viable target. Somatostatin receptors have been targeted in gliomas and also in meningiomas as well, and there are trials underway, though, just now to use to use intravenous lutetium dotatate in GBM. And here you can see a GBM tumour. This is before treatment, quite intense uptake in the tumour here, and then after several cycles of therapy, this uptake has actually reduced at many sites. There's a whole host of sort of fringe targets, neurokinin receptors, substance P, which there have been sort of case series of these also described in the literature, but still they having problems trying to make their way through to the clinic. In terms of trying to target the LAT1, there have been a couple of trials which are now underway or have just completed with this, and it's quite an exciting place to be just now. But the trouble is, though, is that these tracers require the blood-brain barrier to have broken down. There's a few other ones, chemokine receptors. You can see here you don't have any uptake on the FDG, but you've got quite high uptake in the grade 3 and grade 4 tumours, also in lymphoma as well. And I think no talk would be complete without talking about FAPI, which is which is on its way to image the cancer-associated fibroblasts. So, the sort of point here is that it's in the extracellular matrix. It inhibits the immune response and essentially creates a physical barrier and promotes angiogenesis. And there has been some work here which has shown that FAP is actually a potential target for GBMs. Neuroinflammation, TSPIO imaging, there's quite a lot, but you're not just imaging microglia activity, you're imaging quite a lot else, but it is there. And then we've now got PARP inhibitors as well, which have made their way through to the clinic, and we are hopefully going to be starting a clinical trial at KCL with PARP. Last two slides quickly, just to talk about meningiomas. I think most of us here know that dotatate tracers can be used to treat this if they are not surgically resectable. But finally, I just want to end with metastatic brain tumours. I mean, these are the most common brain tumours, but we don't talk about them enough. A lot of these targets can be used for brain metastases as well, and there are clinical trials ongoing in this field. So I guess just to round up, hopefully this sums up all three. FDG PET, dubious whether it's particularly useful outside of CNS lymphoma. Amino acid PET tracers, yes, good. Somatostatin receptor imaging, definitely for meningiomas. But I think as we go forward, combination therapies with MRT will be required, including radiosensitizers, immunotherapies, and other tumour modifiers and external beam. But we desperately need more dedicated multi-center clinical trials on this, and this is where I think we are actually failing just now. If I'm honest, we have to really focus ourselves on this, particularly when we're trying to introduce these new theranostic agents and provide the evidence base going forward. Okay. Thank you very much.